You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about pulmonic stenosis and pulmonic regurgitation. We'll start with the epidemiology of pulmonic stenosis, then talk about presentation, imaging, and intervention. The most common cause of pulmonic stenosis is congenital. Normal pulmonic valves are trileaflet, but congenital pulmonic stenosis may be trileaflet, bicuspid, unicuspid, or dysplastic. Acquired pulmonic stenosis can be from carcinoid disease or rheumatic disease. Congenital pulmonic stenosis almost always has a dilated pulmonary artery, regardless of the degree of the stenosis. Pulmonary stenosis is the most common cardiac manifestation of Noonan syndrome. The second most common cardiac manifestation of Noonan syndrome is hypertrophic cardiomyopathy. 80% of Noonan syndrome patients have congenital heart disease, and their congenital heart disease is pulmonic stenosis or hypertrophic cardiomyopathy. 30% of Turner syndrome patients have congenital heart disease, and their congenital heart disease is bicuspid aortic valve or coarctation of the aorta. Noonan syndrome is autosomal dominant and associated with a mutation in the PTPN gene on Q24. Only females are affected by Turner syndrome, whereas Noonan syndrome can occur in males or females. The pulmonary stenosis of Noonan syndrome can be valvular or supravalvular. Presentation. The click of pulmonic valve stenosis is due to a stiff and mobile pulmonic valve, much like the aortic valve. However, with inspiration, the stenotic pulmonary valve is partially opened prior to systole by the atrial click into the stiff thickened right ventricle. This results in a reduced excursion of the pulmonic valve with inspiration and a reduction in the intensity of the pulmonary click with inspiration. The early click of pulmonary stenosis is commonly referred to as the only right-sided event that declines in intensity with inspiration. Meanwhile, the murmur itself of pulmonary stenosis increases with inspiration. Click is a term only used in systole. Early systolic click equals ejection click. This term means aortic stenosis if it's in the right upper sternal border, which is most common and does not vary with inspiration, whereas it means pulmonic stenosis if it is at the left upper sternal border and decreases in intensity with inspiration due to the reduced excursion. Lastly, a loud click in early systole can also be from Ebstein's anomaly, also known as the sail sound emanating from the large anterior tricuspid valve leaflet as it billows backwards in systole. A mid or late systolic click or non-ejection click refers to mitral valve prolapse as blood retrogradely flows from the LV to the LA. Mitral valves maintain themselves at first, but then chordae tendineae suddenly prolapse and tense up. Upon standing or with Valsalva, the mid-systolic click of mitral valve prolapse will occur earlier in systole. That's a little brief aside on click, which is a term only used in systole, and how you can differentiate the click of aortic stenosis, pulmonic stenosis, or Ebstein's anomaly, or mitral valve prolapse. Now we'll go back to pulmonic stenosis. Imaging of pulmonic stenosis. RV hypertrophy develops in severe PS or PS that has significant concomitant PR. The severity of the RV outflow tract obstruction is quantified by both peak velocity and mean gradient. Pulmonary peak velocity more than 4 meters per second suggests severe PS, and less than 3 suggests mild PS. Pulmonary peak gradient of more than 64 millimeters of mercury suggests severe PS, and less than 36 suggests mild PS. Pulmonary valve mean gradient more than 35 millimeters of mercury suggests severe PS. This is a new change in the guidelines. In pulmonic stenosis, the RV systolic pressure does not equal the pulmonary artery systolic pressure. Now, how about intervention? In patients with moderate or severe isolated pulmonary valve stenosis, pulmonary balloon valvuloplasty is safe and effective in reducing the pulmonary valve gradient and improving symptoms in most patients. Surgery is reserved for those who fail balloon valvuloplasty of the pulmonic valve. In terms of surgical valve replacement versus surgical valvotomy, surgical valvotomy is usually sufficient, particularly when the pulmonary annulus is not hypoplastic. Pulmonary valve replacement may be necessary when there is marked dysplasia of the pulmonary valve or significant hypoplasia of the annulus. According to the 2018 Congenital Heart Guidelines, In adults with moderate or severe valvulopulmonary stenosis and otherwise unexplained symptoms of heart failure, cyanosis from intraatrial right to left communication, and/or exercise intolerance, balloon valvuloplasty is recommended. That is a Class 1 recommendation. In adults with moderate or severe valvular pulmonary stenosis and otherwise unexplained symptoms of heart failure, cyanosis, and/or exercise intolerance who are ineligible for or who fail balloon valvuloplasty, surgical repair is recommended. That's a Class 1 recommendation. In asymptomatic adults with severe valvular pulmonary stenosis, intervention is reasonable, Class 2A. So they allow intervening in asymptomatic severe PS because it will reduce the RV pressure and the potential for worse sequelae down the road. Now, how about branch and peripheral pulmonary stenosis? So this is non-valvular pulmonic stenosis. Pulmonic stenosis can occur in the pulmonary arteries or the branches of the pulmonary arteries independent of having any pulmonic valvular stenosis. Pulmonary branch and peripheral pulmonary stenosis can be isolated, occur as a part of a constellation of right ventricular outflow tract obstruction, or be found in association with a syndrome such as Noonan's, Alagille, Williams, or maternal rubella exposure. The 2018 Congenital Heart Guidelines say, in adults with peripheral or branch pulmonary artery stenosis, pulmonary artery dilation and stenting can be useful. That's a Class 2A recommendation. Now, pulmonic regurgitation. The three cuffs of the pulmonic valve are anterior, right, and left, but it is nearly impossible to identify these on the echo. Pulmonary regurgitation can be congenital, carcinoid endocarditis, post-op, or from PA dilation. How do we define severe PS? A jet width is more than 50%, jet length less than 10 millimeters. You'll have holodiastolic reversal of flow in the branch pulmonary artery, a dense CW Doppler, but eccentric jets may have less density, and a pressure half time less than 100 milliseconds. It's dependent on PA pressure and RV diastolic dysfunction. The jet duration, if it ends before systole, then it is more than mild, so moderate or severe. Either surgical or catheter intervention on pulmonic stenosis may result in hemodynamically important pulmonary regurgitation that can result in symptoms, RV enlargement, and/or dysfunction requiring pulmonary valve replacement. So there's a whole section in the Congenital Heart Guidelines of 2018 that talks about pulmonary regurgitation that develops after intervention on pulmonic stenosis. So what do they say about that? In symptomatic patients with moderate or greater PR, pulmonic regurgitation, resulting from treated isolated pulmonary stenosis with RV dilation or RV dysfunction, pulmonary valve replacement is recommended. That's a Class 1 recommendation. For asymptomatic patients with residual pulmonic regurgitation resulting from treatment of isolated pulmonary stenosis with a dilated right ventricle, serial follow-up is recommended, Class 1. What about in asymptomatic patients? In asymptomatic patients with moderate or greater pulmonary regurgitation resulting from treatment of isolated pulmonary stenosis with progressive RV dilation and/or RV dysfunction, pulmonary valve replacement may be reasonable, Class 2B. So, basically, pulmonary valve replacement should be done for symptomatic, moderate, or severe PR, just observed if asymptomatic, but intervention is allowed for asymptomatic if there is progressive right ventricular dilation or right ventricular dysfunction. That's all you need to know for pulmonic stenosis and pulmonic regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.